Welcome to the deep dive. Today we're focusing on mumps. Really important topic, especially if you're in healthcare training.
Absolutely. We want to give you a solid handle on it. We're using a source called the Comprehensive Mumps Guide today.
Right, and the plan is to pull out all the key bits, the stuff you really need to know for, understanding it quickly and remembering it.
Exactly. We'll cover the basics, what it is, the cause, risks, what's happening physiologically,
How it presents, differentials, epidemiology, investigations.
management, prognosis, and those potential complications too. And we'll try to sprinkle in some memory aids along the way.
Great, so let's jump right in. The definition. What exactly is mumps?
Okay, so mumps is fundamentally a contagious viral infection. The thing it's most known for is affecting the salivary glands, especially the parotids, causing pain and swelling.
That classic swollen cheek look.
Precisely. But it's caused by the mumps virus, which is a paramyxovirus, and it's important to know it doesn't always stop at the salivary glands.
Ah, right. It can affect other parts of the body.
Yes, potentially the testes in males, ovaries in females, the pancreas, even the brain sometimes.
Oh, okay. And it has another name too, doesn't it?
It does. It's sometimes called epidemic parotitis. And crucially, for anyone listening in the UK, it is a notifiable disease.
Good point. Important for public health tracking.
Definitely. And that virus, the paramyxovirus, it's pretty common, particularly in kids and young adults.
Okay. What about incubation? How long after exposure do symptoms show up?
It's quite a range, actually. Typically 12 to 25 days. The average is usually around 16 to 18 days.
16 to 18 days. So you could be spreading it before you even feel sick. How does it spread?
Yeah, that's a key point. It's highly infectious. The main route is saliva droplets. Think coughing, sneezing, even talking close to someone.
So close personal contact is the main risk there.
Absolutely. And people are most infectious from about 1 or 2 days before symptoms start, up until about 9 days after the swelling begins.
That's a long window of infectivity.
It really is. And adding to that, maybe 15 to 20% of infections are asymptomatic, so people can have it, spread it, but show no signs at all.
Right. And even those people can shed the virus.
Yes, before and after when symptoms would typically appear. Usually, though, getting mumps once gives you lifelong immunity. Reinfection is very rare, like 1 or 2%.
Which makes that notifiable status even more critical for tracking vaccine effectiveness, I suppose.
Exactly. It all ties together for public health monitoring.
Okay, let's try a quick memory jog for the definition points. How about MPS? M for myxovirus, the virus family. U for UK, notifiable. M for mainly salivary glands. P for painful swelling. And S for saliva spread.
That works well. Covers the core concepts nicely.
Great. So moving on to the etiology, the direct cause.
We've sort of covered it, but just to be explicit, the direct cause is the mumps virus, which is a paramyxovirus.
And transmission is primarily
Respiratory droplets. From someone infected coughing, sneezing, talking. That's the main way it gets around.
Are there other ways like touching things?
Well, yes, close contact definitely helps it spread. Sharing things like cups or cutlery could potentially transmit it if there's contaminated saliva. And touching surfaces with the virus and then touching your face, mouth, nose, eyes, that's also a possible route, though maybe less common than direct droplets.
Okay. Standard hygiene helps then. Quick question for you listening. What's the primary way mumps spreads?
And the answer is respiratory droplets.
Perfect. Now, who's most at risk? What are the key risk factors?
The biggest one, without a doubt, is lack of vaccination. The MMR vaccine, measles, mumps, rubella, is highly effective. So being unvaccinated or incompletely vaccinated puts you at much higher risk.
Makes sense. What else?
Close contact, as we just discussed, being around someone who's actively infected obviously increases your chances.
And environments. Does that play a role?
Definitely. Crowded places are riskier. Think schools, university dorms, military barracks, anywhere people are living or working in close quarters. The virus just spreads more easily then.
Right, so lack of vaccine, close contact, crowded spaces. Let's try another mnemonic. No crowds, N for no vaccination, C for close contact, and Rowdy for crowded environments.
I like it. Simple and covers the main points.
Okay, let's get into the pathophysiology that's actually happening inside the body.
So it starts when the virus gets into the respiratory tract. Nose, throat, that's the entry point.
The usual route for respiratory viruses.
Exactly. But from there, it doesn't just stay put. It travels, and it really likes the salivary glands, particularly those parotid glands near the ears.
And that's where the swelling happens.
Yes. The virus gets into the gland cells and starts replicating, making copies of itself. The body's immune system then reacts to this invasion, causing inflammation, and that's the pain and swelling we see.
So it's the immune response causing the main symptom.
Pretty much. But the virus can also get into the bloodstream. That's called viremia. And from the bloodstream, it can spread to other organs.
Ah, okay. That's how you get those other complications we mentioned earlier, like orchitis or meningitis.
Precisely. That dissemination through the blood is what allows it to potentially affect the testes, ovaries, pancreas, central nervous system, and so on.
It's quite a journey for the virus.
You could think of it like a traveler. Starts at the airport, the respiratory tract, takes a flight to a major hub, the salivary glands, causes disruption there, then maybe catches connecting flights to other places, the other organs.
That's a helpful way to picture it. Okay, so if someone comes in with swollen glands, it's not always mumps, right? What else should be on the differential diagnosis list?
That's a crucial point. Mumps is a common cause of parotitis gland inflammation, but not the only one. You have to consider other things.
Like what?
Well, other viruses can cause parotitis, sometimes bacteria too. HIV infection can sometimes present with salivary gland issues.
Okay.
And then there's things like a blocked parotid duct, a salivary stone, that
Yeah.
often causes swelling and pain that gets worse when you eat because you're producing more saliva that can't get out.
The timing of pain could be a clue there.
It can be. Also, if someone has signs of meningitis or encephalitis, like headache, stiff neck, confusion mumps should be considered as a potential cause, even if they don't have obvious parotid swelling.
Right. What about testicular pain? You mentioned orchitis.
Yes, mumps orchitis needs differentiating from testicular torsion. Torsion is a surgical emergency where the testicle twists on its cord, cutting off blood supply. It often happens in a similar age group.
But the presentation is different.
Usually, yes. Torsion tends to be a very sudden, very severe pain onset. Mumps orchitis might develop a bit more gradually alongside other mumps symptoms, but it needs careful assessment.
Definitely. Anything else for the differential?
You might think about other systemic viral illnesses like rubella, though usually the rash is distinctive there. And occasionally drug reactions or even allergic reactions could cause facial swelling.
So a broad range of possibilities. Good reminder to be thorough. Okay, example question time. A young man presents with sudden, severe, one-sided testicular pain. Mumps orchitis is one thought, but what urgent condition must be ruled out?
That would be testicular torsion.
Exactly. Okay, let's zoom out now to epidemiology. How common is mumps, especially here in the UK?
Well, the big story with mumps epidemiology is vaccination. It's a vaccine-preventable disease, and the MMR vaccine has dramatically reduced cases in the UK and elsewhere.
So it's much less common than it used to be.
Oh, absolutely. High vaccination rates have made a huge difference. But, and this is important, we still see sporadic outbreaks. These often happen in groups where vaccination uptake might be lower.
Like specific communities or age groups?
Yeah. The MMR was introduced in the UK back in 1987. Since about 2004, interestingly, many of the cases and outbreaks have been linked to universities.
Universities. Why there specifically?
Likely a combination of factors. Close living in halls of residence, social mixing, and perhaps some cohorts of young adults who missed out on full vaccination when they were younger.
That makes sense. So we still see clusters.
We do.
Wow.
In fact, there was quite a significant rise in cases in the UK in 2019, mostly among young adults who weren't fully vaccinated.
How significant? Do we have numbers?
Yes, in England alone in 2019, there were 5,042 lab-confirmed cases. That was the highest number since 2009.
Wow, okay. So it really highlights that even with good overall vaccine coverage, if you get pockets of susceptible individuals, especially in close contact settings,
you can get outbreaks, exactly. Vaccination works, but we need to maintain high coverage everywhere.
key takeaway there. Right, let's talk clinical presentation. What does mumps typically look like?
The classic sign is that painful swelling of the parotid glands, usually bilateral both sides, but can be unilateral. That's the hallmark.
The hamster cheeks.
That's the one. Alongside that, people often get fever, headache, muscle aches, myalgia, fatigue, maybe loss of appetite, kind of general viral symptoms as well.
And does the swelling always come first?
Not always. Sometimes those nonspecific symptoms, the fever, headache, fatigue, can appear a few days before the glands swell up. That's called a prodrome.
Okay. And is it just the parotids?
Mostly, but sometimes the other salivary glands under the jaw, the submandibular and sublingual glands, can get involved too. Jaw pain is common with the swelling. It usually lasts a few days, then gradually gets better.
I mean, you have to remember some people get no symptoms at all.
Right, the asymptomatic cases. But for those who do get symptoms, what about the complications? How does orchitis present?
Yes, orchitis. Clinically, that usually involves chills, sweats, pretty severe testicular pain and swelling. More often one-sided, but can be both. It's worrying, but it rarely causes long-term infertility.
Good to reiterate that. And meningitis.
If the nervous system gets involved, you might see signs of meningitis, headache, fever, stiff neck, light sensitivity. That happens in maybe 15% of cases. Less commonly, it can progress to encephalitis, which is brain inflammation, and more serious.
So, quite a range of possibilities. Let's try a mnemonic for the common symptoms. PHMFL. P for parotid swelling, H for headache, M for muscle aches, F for fever, and L for loss of appetite or fatigue.
PHMFL.
Got it.
Okay. How do we confirm the diagnosis? What investigations are done?
Well, historically, especially during an outbreak, the diagnosis was often clinical. You see the classic swollen parotids, maybe know there's mumps going around.
And you make the call based on that.
Yeah. But now, particularly because vaccination can sometimes lead to milder or slightly different symptoms, lab confirmation is recommended for all suspected cases in the UK.
Okay, so clinical suspicion isn't enough anymore.
It's the starting point. But you need that lab confirmation. You have to report suspected cases to the local health protection unit, the HPU.
And what sample do they need?
The standard test uses an oral fluid sample, basically a swab of the inside of the mouth. That gets sent off to look for the Mumps virus, usually using PCR.
Okay. What if someone has, say, meningitis symptoms but no parotid swelling? How do you check for mumps then?
Good question. In those cases, you typically test their blood serum for mumps-specific antibodies, particularly IgM, which indicates recent infection. Saliva testing might still be useful too, and the HPU can help arrange that. Sometimes if the first test is negative, but you still strongly suspect mumps, you might need to repeat the test later.
Right. And for people who've been vaccinated but get sick anyway.
For them, the RT-PCR test on the oral fluid sample is very useful. It can confirm the infection and even do genotyping to see the specific strain of mumps virus involved.
Interesting. And going back to orchitis versus torsion.
Ultrasound is key there. A high-resolution color Doppler ultrasound can look at blood flow to the testicle. In torsion, the blood flow is usually reduced or absent. In mumps orchitis, it should still be present, though maybe increased due to inflammation.
So imaging is crucial for that differential. Okay, the key point seems to be always aim for lab confirmation now. So once it's diagnosed, how's mumps managed?
Management is largely supportive. There's no specific antiviral drug that cures mumps.
So you just treat the symptoms?
Exactly. Focus on keeping the person comfortable. Make sure they drink plenty of fluids. Keeping the mouth moist can help too, as the swollen glands can be uncomfortable.
And for pain and fever?
Simple analgesics like paracetamol or ibuprofen are the mainstays. They help with the fever, the headache, the muscle aches, and the pain from the swollen glands.
Okay. What about for orchitis? Any specific treatment?
It's still mainly conservative management, bed rest, plenty of fluids, regular analgesia like paracetamol or ibuprofen. Some find scrotal support helpful for comfort.
And preventing spread?
Yeah, that's important. Isolation is usually recommended. Public health guidance typically advises staying off school or work for about 5 days after the parotid swelling starts to reduce transmission to others.
Right. So rest, fluids, pain relief, and isolation. Sounds like the core plan. What's the general outlook, the prognosis?
Generally very good for uncomplicated mumps. Most people recover fully within a week or two. It's usually a self-limiting illness.
That's reassuring, but complications can happen.
They can, though they are rare. We mentioned orchitis, meningitis, encephalitis. About 1 in 1,000 cases of mumps meningitis might progress to encephalitis.
And encephalitis can be serious.
Yes, it carries a fatality rate of around 1.5%, which is low but obviously significant if it happens. Deaths from other mumps complications are very rare, mostly seen in males over 19.
So overall, most people do well, but complications need to be watched for. Let's quickly recap those complications.
Okay, so orchitis in males, ophiritis, ovary inflammation in females, meningitis and encephalitis affecting the nervous system.
What else?
Pancreatitis inflammation of the pancreas occurs in about 4% of cases. Deafness, usually temporary sensorineural hearing loss, affects about 4 in 1,000, but permanent deafness is rare.
Any others?
There are rarer things reported, like neuritis, arthritis, nephritis affecting the kidneys, thyroiditis, pericarditis around the heart, even mild mastitis.
Wow, quite a list. What about mumps during pregnancy?
If it occurs in the first trimester, there might be a slightly increased risk of miscarriage. But importantly, mumps isn't known to cause birth defects. It's not teratogenic.
Okay, and prevention wraps back around too.
MMR vaccination. That's the #1 way to prevent mumps and its complications. It's part of the national program. Good hygiene hand washing, covering coughs, also helps reduce spread within households, and that school exclusion rule for 5 days after swelling starts.
And it's worth remembering that complications tend to be more common in adults and adolescents than younger kids.
Absolutely, which really reinforces the importance of making sure everyone is fully vaccinated, regardless of age if they missed doses earlier.
Okay, so we've covered a lot. Definition, cause, spread, symptoms, diagnosis, management, prognosis, complications, the whole picture. And the recurring theme is the effectiveness and importance of the MMR vaccine.
Definitely. A really vital tool in controlling this disease. Hopefully this deep dive gives you a solid grounding. Take some time to review the key points. Maybe think about how you'd approach a patient presenting with these symptoms.
Absolutely. And here's something to ponder, linking back to that 2019 data. Considering those university outbreaks among young adults, what strategies, maybe going beyond just individual vaccination reminders, could universities or public health bodies implement to try and boost immunity and reduce mumps transmission in those specific settings? Food for thought.
An interesting challenge.
Indeed. If you want more revision resources or want to test yourself, don't forget to check out PassTheMSRA.com and FreeMSRA.com.
Great resources there.
Thanks so much for joining us for this deep dive into mumps.